Musculoskeletal system. All services that appear in the musculoskeletal system section, including the application and removal of the first cast, splint, or traction device. When performed, supplies may be reported separately. If a cast is removed by someone other than the physician or qualified healthcare professional who applied the cast, report a cast removal code 29700, 29705, 29710. Subsequent replacement of a cast, splint, or strapping 29000 through 29750 and/or traction device, e.g. 20690 during or after the global period may be reported separately. A cast, splint, or strapping is not considered part of the preoperative care. However, the use of modifier 56 for preoperative management only is not applicable. Codes for obtaining autogenous bone graft, cartilage, tendon, fascial autograft, or other tissues through separate incisions are to be used only when the graft is not already listed as part of the basic procedure. Fractures and/or dislocation treatment. Fracture and dislocation treatment codes appear throughout the musculoskeletal system. These codes are categorized by the type of treatment, closed, percutaneous, open, and the type of stabilization, fiction, immobilization. There is no coding correlation between the type of fracture dislocation, for example, open, compound, closed, and the type of treatment, for example, closed, percutaneous, open, provided. For example, a closed fracture may require open treatment. Fracture dislocation treatment definitions. Manipulation, reduction by the application of manually applied forces or traction to achieve satisfactory alignment. Fracture or dislocation, if satisfactory alignment, reduction, is not maintained and requires subsequent re-reduction of a fracture or dislocation by the same physician or qualified healthcare professional. Append modifier 76 to the fracture dislocation treatment code. Traction, the application of a distracting or traction force to the spine or a limb. Skeletal traction includes a wire, pen, screw, or clamp that is attached to, penetrates, bone. Skin traction is the application of force to a limb, using strapping or a device that is applied directly to the skin only. Closed treatment, the treatment site is not surgically opened, that is, not exposed to the external environment nor directly visualized. Closed treatment of a fracture dislocation may be performed without manipulation. For example, application of cast, splint, or strapping, with manipulation, with skeletal attraction, and/or with skin traction. Casting, splinting, or strapping used solely to temporarily stabilize the fracture for patient comfort is not considered closed treatment. Percutaneous skeletal fixation, treatment that is neither open nor closed. In this procedure, the fracture fragments are not visualized, but fixation, for example, pins, screws, is placed across the fracture site, typically with imaging guidance. Open treatment, the site is opened surgically to expose the fracture dislocation to the external environment for treatment, or the fracture dislocation is treated through the traumatic wound or an extension thereof is treated with an intramedullary nail or other internal fixation device placed through a surgical exposure that is remote from the fracture site with or without the direct visualization of the fracture site. External fixation, the use of pins and/or wires that penetrate the bone and interconnection devices, for example, clamps, bars, rings. For fracture dislocation treatment, external fixation may be used for temporary or long-term fracture dislocation treatment. Uniplanar external fixation places all the pins in approximately the same plane, but may also include triangle fixation across a joint. Multiplanar external fixation uses transosseous wires and threaded pins placed in several planes that are held with interconnected stabilizing and/or tensioning rings and/or half rings. External fixation may be used for all types of fractures dislocation treatment, that is, closed, percutaneous, open. Codes for external fixation are reported separately only when external fixation is not listed in the code's descriptor as inherent to the procedure. Reporting fracture and/or dislocation treatment codes. The physician or qualified healthcare professional providing fracture dislocation treatment should report the appropriate fracture dislocation treatment code for the service he or she provided. If the person providing the initial treatment will not be providing subsequent treatment, modifier 54. Modifier 54 surgical care only, should be appended to the fracture dislocation treatment code. If treatment of a fracture as defined above is not performed, report an evaluation and management code. Excision resection soft tissue tumors definitions. Excision of subcutaneous soft connective tissues tumors including simple or intermediate repair involving the simple or marginal resection of tumors, confined to subcutaneous tissue below the skin, but above the fascia. These tumors are usually benign and are resected without removing significant amount of surrounding normal tissue. Code selection is based on the location and size of tumor. Code selection is determined by measuring the greatest diameter of the tumor plus that margin required for complete excision of the tumor. The margins referred to the most narrow margin required to adequately excise the tumor. Based on the physician's judgment, the measurement of the tumor plus margin is made at the time of excision. Appreciable vessel, expiration, and/or neuroplasty should be reported separately. Extensive undermining or other techniques to close a defect created by a skin excision may require a complex repair, which should be reported separately. Dissection or elevation of tissue planes to permit resection of the tumor is included in the excision. For excision of benign lesions of cutaneous origin, for example, sebaceous cyst, C11400 through 11446. Excision of fascial or subfacial soft tissue tumors including simple or intermediate repair involves the section of a tumor confined to the tissue within or below the deep fascia, but not involving the bone. These tumors are usually benign, are often intramuscular, and are resected without removing a significant amount of the surrounding normal tissue. Code selection is based on the size and location of the tumor. Code selection is determined by measuring the greatest diameter of the tumor plus the margin required for complete excision of the tumor. The margins referred to the narrow margin required to adequately excise a tumor. Based on individual judgment, the measurement of the tumor plus margin is made at the time of the excision. Appreciable vessel, expiration, and/or neuroplasty should be reported separately. Extensive undermining or other techniques to close a defect created by skin excision may require complex repair, which should be reported separately. Dissection or elevation of tissue planes to prevent resection of tumor is included in excision. Digital, that is, finger and toes. Subfascial tumors are defined as those tumors involving the tendon sheaths, or joints of the digit. Tumors which simply abut, but do not breach the tendon sheath, or joint capsule are considered subcutaneous soft tissue tumors. Radical resection of soft connective tissue tumors including simple or intermediate repair involves the resection of the tumor with wide margins of a normal tissue. Appreciable vessel, exploration and/or neuroplasty repair or reconstruction. For example, adjacent tissue transfers, flap, should be reported separately. Tensive undermining, or other techniques to close a defect created by skin excision may require complex repair, which should be reported separately. Dissection or elevation of tissue planes to permit resection of the tumor is included in the excision, although these tumors may not be confined to a specific layer. For example, subcutaneous, subfascial, radical resection may involve removal of tissue from one or more layers. Radical resection of soft tissue tumors is most commonly used for malignant connective tissue tumors, or a very aggressive benign connective tissue tumor. Code selection is based on site and location of the tumor. Code selection is determined by measuring the greatest diameter of the tumor plus that margin required for complete excision of the tumor. The margins referred to the most narrow margin required to adequately excise the tumor. Based on individual judgment, the measurement of the tumor plus margin is made at the time of the excision. For radical resection of tumor of cutaneous origin, for example, melanoma, C11600 through 11646. Radical resection of bone tumors, including simple or intermediate repair involves the resection of the tumor with wide margins of normal tissue. Appreciable vessel exploration, and/or neuroplasty and complex bone repair or reconstruction. For example, adjacent tissue transfer, flap, should be reported separately. Extensive undermining or other techniques to close a defect created by skin incision may require a complex repair, which should be reported separately. Dissection or elevation of tissue planes to permit resection of tumor is included in the excision. It may require removal of entire bone if tumor growth is extensive. For example, clavicle. Radical resection of bone tumors is usually performed from malignant tumors or very aggressive benign tumors. If surrounding soft tissue is removed during these procedures, the radical resection of soft tissue tumors code should not be reported separately. Code selection is based solely on the location of the tumor, not on the size of the tumor or whether the tumor is benign or malignant, primary or metastatic. General, wound exploration, trauma. For example, penetrating gunshot, stab wound. 20100 through 20103 relate to wound S resulting from penetrating trauma. These codes describe surgical exploration and enlargement of wound, extension of dissection, to determine penetration, debridement, removal of foreign body, S, ligation or coagulation of the subcutaneous and/or muscular blood vessel, S, of the subcutaneous tissue, muscle fascia, and/or muscle, not requiring thoracotomy or laparotomy. If a repair is done to a major structure or blood vessel requiring thoracotomy or laparotomy, then those specific code, S, would supersede the use of codes 20100 through 20103, to report simple, intermediate, or complex wounds that do not require enlargement of the wound, extension of dissection, etc. As stated above, use specific repair codes in the integumentary system section. Manual preparation involves the mixing and preparation of antibiotics or other therapeutic agents with a carrier substance by the physician or other qualified healthcare professional during the surgical procedure and then shaping the mixture into a drug delivery device. For example, beads, nails, spacers, for placement in the deep, for example, subfascial, intramedullary, or intra-articular spaces. Codes 20700, 20702, 20704 are add-on codes for the manual preparation and insertion of the drug delivery devices. They may be used with an open procedure code except those that include the placement of a spacer. For example, 27091, 27488. The add-on codes may be used when infection is present, suspected, or anticipated during the surgery. The location of the primary service determines which of the insertion codes may be selected. If the primary surgery is in the deep, subfascial region, add-on code 20700 may be reported. If the primary surgery is within the bone or intramedullary, add-on code 20702 may be reported. If the primary surgery is within the joint, add-on code 20704 may be reported. Codes 20701, 20703E, 20705 are add-on codes used to report removal of drug delivery devices. These codes may be typically associated with specific surgeries if the infection has been eradicated. For removal of a drug delivery device from deep, subfascial space performed in conjunction with the primary procedure, that is, complex wound closure, 13100 through 13160, adjacent tissue transfer, 14000 through 14350, or a flap closure, 15570 through 15758. Add-on code 20701 may be reported. For infection that has not been eradicated, see the tissue debridement codes. For example, 11011, 11012, 11042, through 11047. For the primary procedure, if a subsequent new drug delivery device is placed, 20700 may be additionally reported. Similarly, for an add-on code 2703, removal of drug delivery device from the bone may be associated with different procedures. If the infection has been eradicated and the drug delivery device removal is the only procedure being performed, report 20680. Removal of deep hardware, bony reconstruction performed in conjunction with eradication of infection may be reported using the reconstruction as the primary procedure. Persistent infection that is treated using an additional bony debridement procedure may be reported using the debridement as primary procedure. Amputation performed in conjunction with delivery of a new, manually prepared drug delivery device may be reported with add-on code 20702. When joint infection is present, suspected, or anticipated, add-on code 20704, for manual preparation of an intra-articular drug delivery device, may be reported. Code 20704 may not be reported when the placement of a spacer is included in the code. For example, 2, 7, 0, 9, 1 and 2, 7, 4, 8, 8, or when antibiotic cement is used for implant fixation. Add-on code 20705, for removal of a manually prepared, intra-articular drug delivery device, may be typically used in conjunction with a joint stabilization procedure, such as arthrodesis. If no primary service is associated with add-on code 20705 space and the joint is left without remaining cartilage or stabilization, that is, flail joint, Only 2680 may reported. Insertion of a prefabricated drug device may not be reported with 20700, 20702, 20704. Report 20680. If removal of drug delivery device is performed alone, report 20700 through 20705 once per anatomic location. Grafts, or implants. Codes for obtaining autogenous bone, cartilage, tendon, fascial autografts, bone marrow, or other tissues through separate skin facial incisions should be reported separately, unless the code descriptor references the harvesting of the graft or implant. For example, include obtaining graft, autologous grafts that are already defined in the CPT code set, including skin, bone, nerve, tendon, fasciolata, or vessel should be reported with more specific codes for each tissue type. Code 15769 may be used for other autologous tissue grafts harvested by direct excision. See 15771 through 15774 for autologous fat grafting harvested by liposuction technique. Do not append modifier 62. Modifier 62 to surgeons. To bone graft codes 20900 through 20938. Head prosthesis. Codes 21076 through 21089 describe professional services for the rehabilitation of patients with oral, facial, or other anatomical deformities by means of prostheses such as an artificial eye, ear, or nose or intraoral obturator to close a cleft. Codes 21076 through 21089 should only be used when the physician or other qualified healthcare professional actually designs and prepares the prosthesis, that is, not prepared by an outside laboratory. Spine, vertebral column, cervical, thoracic, and lumbar spine. Within the spine section, bone grafting procedures are reported separately, and in addition to arthrodesis. For bone grafts in other musculoskeletal sections, see specific code descriptors and/or accompanying guidelines. To report bone graft performed after arthrodesis, see 20930 through 20938. Do not append modifier 62. Modifier 62 to surgeons. To bone graft codes 20900 through 20938. Example: posterior arthrodesis of L5. S1 for degenerative disc disease utilizing morselized autogenous iliac bone graft harvested through a separate fascial incision. Report as 22612 and 2097. Within the spine section, instrumentation is to report separately, and in addition to arthrodesis, to report instrumentation procedures performed with definitive vertebral procedures. See 22840 through 22855. 22859. Instrumentation procedure codes 22840 through 22840 through 22848, 22853, 22854, 22859 are reported in addition to the definitive procedures. Modifier 2 may not be appended to the definitive or add-on spinal instrumentation procedure codes. Example: posterior arthrodesis of L4, S1. Utilizing moralized autograft iliac bone graft harvested through separate fascial incision. An pedicle fixation. Report as 22612, 22614, 22842, and 20937. Vertebral procedures are sometimes followed by arthrodesis and in addition may include bone grafts and instrumentation. When arthrodesis performed in addition to another procedure, the arthrodesis should be reported in addition to the original procedure with modifier 51. Examples are after osteotomy, fracture, care, vertebral corpectomy, and laminectomy. Bone grafts and instrumentation are never performed without arthrodesis. Example: treatment of a burst fracture of L2 by corpectomy followed by arthrodesis of L1 L3, utilizing anterior instrumentation L1, L3 structural allograft. Report as 63090. 2255851, 22585, 22845, 20931. When two surgeons work together as primary surgeons performing distinct parts of a single reportable procedure, each surgeon should report his/her distinct operative work by appending modifier 62. Modifier 62 to surgeons. To the single operative procedure code, if additional procedures, including on procedures, are performed during the same surgical session, separate codes may be reported by each co-surgeon, with modifier 62. Modifier 62 to surgeons. Appended. See Appendix A. Example: a 40-year-old male with a history of post-traumatic degenerative disc disease at L3-4 and L4-5. Internal disc disruption. Underwent surgical repair. Surgeon A performed an anterior exposure of the spine with mobilization of the great vessels. Surgeon B performed an anterior, minimal, discotomy and fusion L3-4 and L4-5 using anterior interbody technique. Report Surgeon A. 22558 Append modifier 62. 22585 Append modifier 62. Report Surgeon B. 22558 62 Append modifier 62. 22585 62 Append modifier 62. 20931. Excision. For following codes, when two surgeons work together as primary surgeons during distinct parts of partial vertebral body excision, each surgeon should report his/her distinct operative work by appending modifier 62, modifier 62 two surgeons, to the procedure code. In this situation, Modify 62 may be appended to the procedure code 22100 through 22102, 22110 through 22114 and, as appropriate, to the associated additional vertebral or segment add on codes 22103, 22116 as long as both surgeons continue to work together as primary surgeons. Osteotomy. To report arthrodesis, see codes 22590 through 22632. Report in addition to code for definitive procedures with modifier 51 multiple procedures. To report instrumentation procedures, see 22840 through 22855. 2285. Report in addition to codes for distinctive procedures. Do not append modifier 62. Modifier 62 two surgeons. 2 spinal instrumentation codes 22840 through 22848. 22850. 22882, 22858, 22854, 22859. To report bone graft procedures, see 20930 through 20938. Report in addition to codes for definitive procedures. Do not append modifier 62. Modifier 62 two surgeons, to bone graft codes 20900 through 20938. For the following codes, when two surgeons work together as primary surgeons during distinct parts of an anterior spine osteotomy, each surgeon should report his/her distinct operative work by appending modifier 62 to the procedure code. In situations, modifier 62 may be appended to the procedure code and, as appropriate, to associated additional segment add-on codes as long as both surgeons continues to work together as primary surgeons. Spinal osteotomy procedures are reported when a portion of the vertebral segment is cut and removed in preparation for realigning the spine as part of a spinal deformity correction. For excision of an intrinsic lesion of the vertebrae without deformity correction, see 2, 2, 1, 0, 0 through 2, 2, 1, 1, 6. For decompression of the spinal cord and/or nerve roots, see 6, 3, 0, 0, 1 through 6, 3, 0, 0, 8. The three columns are defined as anterior 2/3 of the vertebral body, middle, posterior third of the vertebral body and the pedicle, and posterior, articular facets, lamina, and spinous process. Fracture and/or dislocation. To report arthrodesis, see codes 22590 through 22632. Report in addition to codes for definitive procedure with modifier 51 multiple procedures. To report instrumentation procedures, see 22840 through 22855, 22532, 22854, 22859. To report bone graft, see 2, 0, 9, 3, 0 through 2, 0, 9, 3, 8. Report in addition to codes for definitive procedures. Do not append modifier 62 to bone graft codes. For the following codes, and two surgeons work together as primary surgeons performing distinctive parts of open fracture and/or dislocation procedures. Each surgeon should report his/her distinct operative work by appending modifier 62 to the procedure code. In this situation, modifier 62 may be appended to the procedure codes and, as appropriate, the associated additional fracture, vertebrae or dislocated segment add-on code as long as both surgeons continue to work together as primary surgeons. Percutaneous vertebroplasty and vertebral augmentation. Codes 2, 2, 5, 1, 0 through 2, 2, 5, 1, 5 describe procedures for percutaneous vertebral augmentation that include vertebroplasty of the cervical, thoracic, lumbar, sacral spine and vertebral augmentation of the thoracic and lumbar spine. For the purposes of reporting 2.2.5.1.0 through 2.2.5.1.5, vertebraplasty is the process of injecting a material, cement, into vertebral body to reinforce the structure of the body using imaging guidance. Vertebral augmentation is the process of cavity creation, followed by injection of material, cement under imaging guidance. For 0, 2, 0, 0, T and 0, 2, 0, 1, T sacral augmentation, sacroplasty, refers to the creation of a cavity within the sacral vertebral body following injection of material to fill that cavity. The procedure calls are inclusive of bone biopsy, when performed, and imaging guidance necessary to perform the procedure. Use one primary procedure code and an add-on code for additional levels. When treating the sacrum, sacral procedures are reported once per encounter. Arthrodesis. Arthrodesis may be performed in the absence of the other procedures and therefore when it is combined with another definitive procedure. For example, osteotomy, fracture care, vertebral corpectomy or laminectomy. Modifier 51. Modifier 51 multiple procedures is appropriate. However, arthrodesis codes 22585, 22614, and 22632 are considered add-on procedures codes and should not be used with modifier 51. Modifier 51. To report instrumentation procedures, see 22840 through 22855, 22859, codes 22840 through 22848, 22853, 22854, 22859 are reported in conjunction with codes for definitive procedures. When instrumentation resection or removal is reported in conjunction with other definitive procedures including arthrodesis, decompression, and exploration of fusion, append modifier 51, modifier multiple procedures, to 22849, 22850, 22852, and 22855. To report exploration of fusion use 22830, when expiration is reported in conjunction with other definitive procedures, including orthothesis and decompression. Append modifier 51, modifier 51 multiple procedures, to 22830. Do not append modifier 62, modifier 62 to surgeons, to spinal instrumentation codes, to report bone graft procedures, see 20930 through 20938. Report additional codes for definitive procedures. Do not append modifier 62 to bone graft codes. Procedure codes 22554 through 22558. A single interspace. For additional spaces, use 2.2.5.8.5. A vertebral interspace is the non-bony component between two adjacent vertebral bodies, which contains the intervertebral disc, and includes nucleus pulposus, annulus fibrosus, and two cartilaginous endplates. For the following codes, when two surgeons work together as primary surgeons performing distinctive parts of an anterior body arthrodesis, each surgeon should report his/her distinctive operative work by appending modifier 62 to the procedure code. In this situation, modifier 62 may be appended to the procedure codes and, as appropriate, to the associated additional interspace add-on code 22585 as long as both surgeons continue to work together as primary surgeons. To report instrumentation procedures, see 22840 through 22855, 2289. In addition to codes for distinctive procedures, do not append modifier 62 to spinal instrumentation codes. To report bone graft procedures, see 20930 through 20938. Report in addition to the codes for the definivi produces. Do append modifier 62 to bone grafts codes 20930 through 20938. Definitions. Corpectomy identifies removal of vertebral body during spinal surgery. Facetectomy, the excision of the facet joint between vertebral bodies. There are two facet joints at each vertebral body. Foraminotomy, the excision of bones to widen the intervertebral foramen. The interintervertebral foramen is bordered by the superior notch of the adjacent vertebrae, the inferior notch of the vertebrae, the facet joint, and the intervertebral disc. Laminectomy, removal of a portion of a vertebrae lamina, usually performed for exploration of, access to or decompression of an intraspinal contents. Lamina pertains to the vertebral arc, the flattened posterior proportion of the vertebral arch extending between the pedicles and the midline, forming the dorsal wall of the vertebral foramine. and from the midline junction of the which the spinous process begins. Laminectomy, excision of vertebral lamina, commonly used to denote removal of posterior arch. Laminotomy, excision of a portion of the vertebral lamina, resulting in enlargement of an intervertebral foramen for the purpose of relieving pressure on a spinal nerve. A vertebral segment describes the basic constituent part which the spine may be divided. It represents a single complete vertebral bone with its associated articular process and laminae. A vertebral interspace is the non-bony compartment between two adjacent vertebral bodies which contain the intravertebral disc, and includes the nucleus pulposus, annulus fibrosus, and cartilaginous endplates. Decompression performed on the same vertebral segment, S and/or interspace, S, as posterior lumbar in body fusion that includes laminectomy, facetectomy, and/or foraminotomy be separately reported using 6, 3, 0, 5, 2 and 6, 3, 0, 5, 3. Decompression solely to prepare the interspace for fusion is not important separately. To report instrumentation procedures, see 2, 2, 8, 4, 0 through 2, 2, 8, 5, 5, and 2, 2, 8, 5, 9. Report in addition to the code, S, for the definitive procedure, S. Do not append modifier 62 to bone graft codes 2, 0, 9, 3, 0, through 2, 0, 9, 3, 8. A vertebral segment describes the basic constituent part into which the spine may be divided. It represents a single complete vertebral bone with its associated articular process and laminae. For the following codes, when two surgeons work together as primary surgeons performing distinct parts of an arthrodesis for spinal deformity, each surgeon should report his or her distinct operative work by appending modifier 62 to the procedure code. In this situation, modifier 62 may be appended to procedure codes 2, 2, 8, 0, 0 through 2, 2, 8, 1, 9 as long as both surgeons continue to do work together as primary surgeons. The spinal deformity arthrodesis codes and kyphectomy codes should not be reported in conjunction with thoracic vertebral body tethering codes or lumbar or thoracolumbar vertebral body tethering codes. 0, 6, 5, 6, T and 0, 6, 5, 7, T as well as 0, 7, 9, 0, T. What two surgeons work together as primary surgeons before we distinctive parts of a thoracic vertebral body tethering. Each surgeon should report his or her distinct operative work by appending modifier 62 to the procedure codes. Fire 62 may be appended to procedure code as long as both surgeons continue to work together as primary surgeons. Exploration. To report instrumentation procedures, see 2, 2, 8, 4, 0 through 2, 2, 8, 4, 8 and 2, 2, 8, 5, 9, codes 2, 2, 8, 4, 0 through 2, 2, 8, 4, 8, 2, 2, 8, 5, 3 and 2, 2, 8, 5, 4 as well as 2, 2, 8, 5, 9 are reported in conjunction with codes for definitive procedures. When instrumentation reinsertion or removal is reported in conjunction with other definitive procedures, including arthrodesis, decompression, and expiration of fusion, append modifier 51 to 2, 2, 8, 4, 9 and 2, 2, 8, 5, 0, 2, 2, 8, 5, 2 and 2, 2, 8, 5, 0, 5, code 2, 2, 8, 4, 9 should not be reported with 2, 2, 8, 5, 0 and 2, 2, 8, 5, 2, and 2, 2, 8, 5, 5 at the same spinal level. To report expiration of fusion, see 2, 2, 8, 3, 0. When expiration is reported in conjunction with other distinctive procedures, including arthrodesis, and decompression, append modifier 51 to 2, 2, 8, 3, 0. Spinal instrumentation. Segmental instrumentation is defined as fixation at each end of the construct, and at least one additional interposed body attachment. Non-segmental instrumentation is defined as fixation at each end of a construct and may span several vertebral segments without attachment to the intervening segments. Insertion of spinal instrument is reported separately and in addition to arthrodesis. Instrumentation procedure codes 2, 2, 8, 4, 0 through 2, 2, 8, 4, 8, 2, 2, 8, 5, 2 and 2, 2, 8, 5, 4 as well as 2, 2, 8, 5, 9, To report boning graft procedures, see 2.0.9.0.0 through 2.0.9.3.8. Report in addition to code for definitive procedures. Do not append modifier 62 to bone graft codes 2.0.9.0.0 through 2.0.9.3.8. A vertical segment describes the basic constituent part into which the spine may be divided. It represents a single complete vertebral bone with its associated articular process and laminae. A vertebrae interspaces the non-bony component between two adjacent vertebral bodies, which contains the intervertebral disc, and includes the nucleus pulposus, annulus fibrosus, and two cartilaginous endplates. Code 2.2.8.4.9 and 2.2.8.5.0.2.2.8.5.2 and 2.2.8.5.5 are subject to modifier 51 if reported with other definitive procedures, including arthrodesis, decompression and exploration of fusion. Code 2.2.8.4.9 should not be reported in conjunction with 2.2.8.5.0 and 2.2.8.5.2 as well as 2.2.8.5.5 at the same spinal level. Only the appropriate insertion code 2.2.8.4.0 through 2.2.8.4.8. Codes 22836 through 22838 describe anterior thoracic, vertebral, body tethering, which corrects scoliosis without fusion, and a tether cord to compress the vertical growth plates on the convex side of the curve to inhibit their growth, while allowing the growth plates on the concave side of the curve to continue to grow. Codes 22836 and 22837 may not be reported with interior instrumentation. Codes 22845 through 22847. For the following codes, when two surgeons work together as primary surgeons performing distinctive parts of a thoracic vertebral bodies tethering, each surgeon should report his or her distinctive operative work by appending modifier 62 to the procedure code. Modifier 62 may be appended to procedure code 22836 through 22838, as long as both surgeons continue to work together as primary surgeons. Regions of the spine include cervical, cervothoracic, thoracic, thoracolumbar, lumbar, lumbosacral, sacral, and coccygeal. Shoulder. The area known as the shoulder is made up of the clavicle, scapula, humerus, head and neck, sternoclavicular joint, acromioclavicular joint, and shoulder joint, humerus. The elbow area includes the head and neck of the radio and olecranon process, forearm and wrist, radius, ulna, carpal, bones, and joints, pelvis and hip joint, including head and neck of femur. Arthrodesis code 2.7.2.7. 9 describes percutaneous arthrodesis of the sacroiliac joint using a minimally invasive technique to place an internal fixation device that passes through the ilium, across the sacroiliac joint and into the sacrum, thus transfixing the sacroiliac joint. Report 2.2.7.7.8 for percutaneous placement of an intra-articular stabilization device into the sacroiliac joint using minimal invasive technique that does not transfix the sacroiliac joint. Femur, thigh region, and knee joint, including tibial plateaus. Application of the cast end strapping. All service that appear in the musculoskeletal system section include application and removal of the first cast, splint, or attraction device. When performed, supplies are reported separately. If a cast is removed by someone other than the physician or other qualified healthcare professional who applied the cast, report the cast removal code 2.9.7.0.0 and 2.9.7.0.5 as well as 2.9.7.1.0. Subsequent replacement of cast, splint, or strapping 2.9.0.0.0 through 2.9.7.5.0 and or traction device, for example, 2.0.6.9.0 and 2.0.6.9.2 during or after the global period may be reported separately. A cast, splint, or wrapping is not considered part of preoperative care, therefore, the use of modifier 56 for preoperative management only is not applicable. Removal or repair. Code for cast removal should be employed only for cast applied by another individual.